NAPLEX video number 4. Woot woot. Acute coronary syndrome. Pathophysiology. An atherosclerotic plaque may become unstable and lead to the development of a thrombus. So, an atherosclerotic plaque can break off, go down the vessel, and then occlude there, or it can be flapping and then all of a sudden just flap up and then it can occlude there. Patients may experience ischemia and or infarction of tissue supplied to the occluded artery. Presentation, it's acute, it's sudden, it's like boom, there it is. It can be a chest pressure that radiates to the jaw, the arm, and the shoulders. It can also present as diaphoresis, nausea, vomiting, and a sense of illness. Diagnosis, EKG, cardiac biomarkers such as troponin. Less than 0.03 is normal. Anything higher than that is an elevated troponin. Primary prevention, you use the ASCVD calculator, greater than 10%. Statin, we'll go over dyslipidemia later on, but statins are prevention for acute coronary syndrome. So now let's go with symptomatic treatment. So they just appeared at the ED and you need to treat their acute coronary syndrome. First thing you'll give them is nitroglycerin. Nitroglycerin is an exogenous vasodilator. Oral formulation, so sublingual, it decreases preload while decreasing oxygen demand. The IV formulation reduces ischemia via coronary dilation, increasing O2 supply. So PO is decreasing O2 demand, IV is increasing O2 supply. It's important to note you avoid in patients with evidence of right heart failure, systolic blood pressure less than 90, and if they've had a PDE3 inhibitor in the last 24 hours. If it's tadalafil, then it's the last 48 hours. Now, if nitroglycerin doesn't work, you can use analgesics such as morphine, 2 to 4 milligrams every 5 to 15 minutes. It's a vasodilator in both the veins, preload, and arteries, afterload, increasing O2 supply and decreasing O2 demand. But you need to watch out for respiratory depression. It also may delay the effect and diminish the effect of ticagrelor exposure in patients with MI, so remember that for morphine. We also need O2. We need to make sure that O2 sats are above 90%. You can also give beta blockers and antiplatelets. So let's dive into antiplatelets. We've got aspirin. It irreversibly inhibits the formation of thromboxane A2 through COX gene inhibition, thus inhibiting vasoconstriction, platelet aggregation, and activation. It is recommended that you take 162 to 325 milligrams immediately. Watch out for enteric-coated. You want to chew this aspirin. The effect, it limits the infarct size, it reduces recurrent ischemia and infarct, and improves survival. Clopidogrel is an alternative for true aspirin allergies. Speaking of clopidogrel, P2Y12 inhibitors. They recommend to load a patient with this unless they're going to have cardiac surgery. So load these bad boys. So if they're not going to have surgery, you need to load an antiplatelet. We've got the thienopyridines, which is clopidogrel and prasugrel. They inhibit platelet activation by irreversibly blocking P2Y12 on the ADP receptors. And then we've got the non-thienopyridines, which is ticagrelor and cangrelor, reversibly inhibit P2Y12 receptors at an allosteric site. So ticagrelor, allosteric. You can use dual antiplatelet therapy. It's recommended after PCI, either drug-eluting or bare metal stent, due to decreased risk of rethrombus and recurrent MI. So clopidogrel is a prodrug. You load it 300 or 600 milligrams. It is a CYP2C19. It's metabolized by CYP2C19, so watch out for omeprazole. Give soon or during a PCI. We've got ticagrelor, 180 milligram loading dose. Also give soon or at the time of PCI. Prasugrel, 60 milligram loading dose. So lots of divisible by 60s. give or take an hour after PCI, so that's different. So give it at the PCI or an hour after. It's better than clopidogrel, prasugrel is, but it also causes more bleeding, and it's contraindicated in patients with a history of stroke or TIA. So now we're going to talk about the timing of some things. So after clopidogrel loading dose is given, it takes 1 to 6 hours, depending on the dose, to start working. Prasugrel and ticagrelor, it takes 30 minutes. So clopidogrel takes a while to work. When you discontinue clopidogrel and ticagrelor, it takes 5 to 7 days, but prasugrel, it takes 10 days. And before CABG, you need to stop all antiplatelets for 5 to 7 days. Now let's talk about a class of drugs that we don't talk about that much. It's glycoprotein 2B3A inhibitors. They're IV. They block the final step of platelet aggregation, and it's used during a PCI in STEMI patients to prevent instant thrombosis. It's also used in high-risk patients in bailout therapy. So high-risk patients would be if they have complex lesions, large thrombi, or a high troponin. Bailout therapy is if they have coronary thrombus formation, vessel closure, dissection, or a complex PCI. These drugs are iptafibitide and tirofiban. It's used in addition to antiplatelets and anticoagulation when needed, or abiximab, which is only used for PCI. Okay, now you also need to anticoagulate these patients. Gold standard is unfractionated heparin, 1.5 to 2 times baseline APTT, or 50 to 70 seconds. Or you can use low molecular weight heparin, easy, no routine monitoring, but caution in kidney disease. Fondaparinux. It's preferred if increased risk of bleeding or if they have a history of HIT, heparin-induced thrombocytopenia, and it's not used for PCI. Bivalirudin, PCI planned. It's for when you have a PCI planned, but it's a bridge to the PCI. There's a small bolus of 0.1 milligrams per kilogram and then 2.5 milligrams per kilogram continuous infusion. And if there's no PCI, then you increase the dose. Revascularization therapy. So if you're diagnosed with a STEMI, you either get a PCI or thrombolytics. Thrombolytics catalyze the conversion of plasminogen to plasmin, which degrades fibrin and results in lysis of the thrombus. It can be used up to 12 hours after chest pain onset. Goal is 30 minutes. So door to needle, 30 minutes. PCI, goal is door to balloon is 90 minutes. If 120 minutes or more, planned, fibrolytics. Prevention, anticoagulations for 2 to 8 days and antiplatelets for 14 to 12 months. 14 days to 12 months. Secondary prevention, aspirin 81 milligrams indefinitely. And then P2Y12 inhibitors for 12 months or longer if it's a drug-eluting stent. So ticagrelor may decrease to 60 milligrams twice a day in some patients if it's longer than 12 months. Prasugrel is not recommended for secondary treatment, so prasugrel no-go, not secondary prevention. If cangrelor is used, clopidogrel and prasugrel can be started after cangrelor is stopped. So cangrelor is the only IV antiplatelet of the P2Y12 inhibitors. So if you're going to start prasugrel or clopidogrel, you'd have to wait until cangrelor stopped. But if you're going to start ticagrelor, you can start it when the infusion's still running. If there's a high risk, you can stop after 6 months, but 12 months is preferred. And then there's a new drug, vorapaxar. It's a protease-activated receptor 1 antagonist that can be given with aspirin and/or Plavix for secondary prevention of MI, stroke, or thrombosis. And then we've got statins. Benefits: slows progression of CAD, reduction in mortality, reduction in cardiac events, reduction in inflammation, and inhibits platelet aggregation at ruptured plaque. Beta blockers decrease the heart rate, decreasing O2 demand, increase perfusion of the coronary artery by making it longer diastole, so it's filling more. And you should initiate oral beta blockers within 24 hours of the MI. ACE inhibitors decrease mortality and incidence of recurrent MI. You should avoid estrogens and NSAIDs in acute coronary syndrome. But that is acute coronary syndrome. That was a long one. I apologize. But dyslipidemia is next. Can't wait. See ya.